All right, so, again, thank you everybody for being here today. And again, we're going to continue on with more of a hands-on demonstration of the 3 different types of SBRT immobilization. The first one is somewhat the simplest. It's a compression belt that we put around the patient, and it works with a pneumatic pressure, just like a blood pressure cup. So it's very simple and easy to use. You can put it on the patient while they're sitting up or standing. Sometimes it's easy to put on like a belt that way. And then it's all numbered, so you can index it the same every time you put it on the patient for ongoing treatments. We also have a line on the plate here. We put this underneath the floating ribs and underneath the xiphoid process. And then I can also then line this up on the daily. So right now the patient has, this model has clothing on, but normally they don't. So I would have marks on here so I can line this up in the same spot every time. And then at the time of simulation, we would pump this up to get to a certain compression. And what I usually recommend to everybody is we want to try to get the belt as tight as we can put it on the patient, because then I will have to use less pressure, right? The tighter the belt, the less pressure I have to put in here. And so again, I try to get the maximum amount of pressure the patient can tolerate, because again, if I don't compress as much as possible, then I'm not getting the full benefit of the compression. And what we want to try to do is to cut the patient's breathing in half. So the amplitude of breathing in the ant-to-post direction, we want to cut it in half. So that's why I'm going to try to keep going, and I'm going to ask the patient, how you doing? Okay. So he's allowed to free breathe with this, which is also very good for the patient, because during treatment, there's not a lot of coaching of when to stop breathing and when to breathe in, inhale, and exhale. So it's easy to use. Pretty good. Okay. So now, because of that, he's again, be limited in his breathing. So if I'm treating lungs or gastric cancers, pancreas, things like that, we're going to be able to really target it and not have it move in and out of the area. Once that's done, I'm going to clamp it. I'm going to read what the pressure is on the gauge. I'm going to note that in my simulation notes. And then on the daily treatment, we can just do the same thing each day. Simple and easy to use. I can disconnect this and put a pin on the end. And so this doesn't have to stay with the patient. This is also MRI compatible, so it can be used in an MRI suite, which is also a huge benefit. And that's the simple, easy way to use a compression belt. Jason and I will now show you the next one, which is using manual compression with one of our bridges. And then by releasing it very quickly, you reduce the pressure, so the patient feels pretty good. So the next one we're going to be using is the mechanical compression, which is a bridge, a plate, and then a screw. So the first thing I'm going to do is I'm going to take this paddle, which again, you can see the shape of it. You're going to place that right below the xiphoid, and again, in between the floating ribs, so I'm not going to be pressing on any bony structures. So I place that first because that's going to help direct me where I need to place the bridge on the board. So now I'm going to place the bridge. I'm not going to lock it in just yet, but I'm going to put the screw in here. And now I can go, I'm just going to ask Jason just to move for a second so I can show the group. So now you can move this up and down without it being locked. And so what I'm doing is I'm going to line that up with where it needs to go on the plate. 17. It's all numbered and indexed along the side, so you can place it in the same location every time. There, you might have to just move a little bit there. And we're going to slide it. And you can also raise or lower the bridge up and down. It's all indexed. I always start at the lowest level because, again, it gives me the most clearance. If I'm doing CT or MRI, I don't have anything up high. If I'm doing certain gantry angles, it's not going to get in the way of that as well. So always start at the lowest possible that you can. And again, you're going to start screwing this down and then checking in with the patient. How he's feeling. How you doing? Good. All right. I'm going to slowly go it. And then I usually tell the patient too, I just want to demonstrate that there's a quick release. So don't panic. If you have to get it off very quickly, we can do that. So during simulation, we like to do that just to, again, make sure the patient is a little bit less anxious, because sometimes they get a little anxious with compression. And so it's always good to give them an opportunity to see how quickly you can take it off. So now we're just going to compress slowly. seeing how you're doing. Good. So again, we want to try to get to the maximum allowable because that's going to give us the most benefit. And then here, there's a ruler, so I'm just going to write down whatever number that is right there, put in my simulation notes, and again, we'll be able to reproduce this on the daily in the treatment room. And once again, you saw on that slideshow, we had a picture of somebody doing a SBRT. They had a rubber band on someone's feet. They had some kind of crazy little pillow that was non-indexable. They had, other things for their arms. Here, everything is indexable. Our knee and foot devices are indexable. You can write it all down and set it up the same way every single time. And then as Justin was saying, we're sandwiching the patient from the feet to the head. So now soup to imp, they're in the same spot every day, and then left and right, because again, this is going to take any yaw or out of the equation. So now the patient's straight, level, left to right is the same. So now when I go to do my treatments every day, it expedites the whole process so we can get the patient on and off the table as fast as possible, because a lot of times this isn't the most comfortable. And then again, I can quickly release it. So once we go into the room, we take it off. Okay? So then the next one we're going to show is using our thermoplastics. This is a procedure that was brought to us by Michael Tallhammer, a physicist down in Colorado, the USA. And he's actually produced a white paper on it too, and demonstrated this at conferences and spoke about it. So he has a lot of data on how it works. And so he uses the thermoplastic to compress the patient. And what he has found was internally, I don't want to sometimes, his belief is not just to push straight down, but you want to go down and up. So when we make the mask, we're going to come down below his ribs and we're going to be pressing in the upward motion. And he finds that, this compression is very reproducible and works very well. And again, when we image with MRI, we can actually track the motion of somebody with it in place. And he has data showing how well that works. So we're going to do this with our great model. So normally for this one, there is some coaching. So I usually will talk to the patient and say, I'm going to have you breathe in for me. And then breathe out all the way. We're going to do this 3 times. Breathe in. And then breathe out. And then breathe in. And then breathe out. And hold it. So when we make the mask, we do it on the exhale. So when we go to do this, I'm going to have to coach the patient again to do that. And now you can breathe. Okay. And once we have it in position and we're compressing, then we allow them to breathe. But because we're pushing down on it, we're limiting, again, that amplitude of breathing. So with this particular one, there's a little bit more coaching again with the patient. But again, when we do SBRT, I think all therapists find that there is a lot more coaching with the patient because it's a little bit more involved and we really need to be accurate. So breathe in, breathe out, breathe in, breathe out, and one more time, breathe in, breathe out, and I want you to hold it. Huh? Let's go inner. We need a towel. So we're going to be placing the towel over the patient, pushing down and up. You can breathe. So what we did was we folded the upper part of the mask down under the floating ribs, and we're holding it down with our elbows, and we're pushing also upward. So it's a down and up, which is then pushing or putting pressure on the diaphragm, which really controls that breathing. It is a warm or wet towel, because if we use a dry towel, it could stick to the mask. So we found that using a wet towel works better. And it also then bends a little bit easier into the thermoplastic, so you get a little bit better compression. So, yeah, Scott just said that he does like this a little bit better. So I think that's the other thing that Mike Tallhammer found, that a lot of the patients seem to tolerate it a little bit better. It's compressing it better. And as we know, thermoplastics too, on day 1 or 2 after we make it, they tend to fit a little bit tighter. So it's always going to be nice and snug. So you're never really going to get a loose one on day 2 or 3 when you're treating the patient. It's always going to be really snug and tight on them. one of the things Mike Tallhammer also talks about is when you go to put it on the patient for treatment, you always want to put on one side first. So if you're always putting it on the right-hand side first, then the left, you always want to keep doing it the same way, because that compression could be moving the internal organs a certain way. So by always putting it on the right side, then the left side, will always kind of push things to the same location that they should be. So that's another thing where you're coaching the therapist. We don't want to just go in there and slap it on them really quick. Again, you got to have them on the exhale. And then if I'm putting mine on first, then his for day one, we want to do that throughout their treatment. So now again, once you have the compression that you want and the mask is hardened, you're just going to basically remove the towel. And then you have a nice compression under the ribs, pushing up towards the diaphragm. Again, you can use wet, cold towels to expedite the cooling of the mask. And actually, Mike Tallhammer does recommend that, because, again, it gets nice and hard right away. And then you would take it off the patient, cool it off, put it back on them. Again, I would coach them on the breathing. On the exhale, I'd put it back on them, and then I would do my CT simulation. And then, again, going forward for treatment, always remember, when you place it on the patient, you're going to do the coaching on the third inhale, exhale, you're going to put it on. And if I put on the left side first and then the right, you're going to do that for every fraction, because this is going to push the internal organs in a certain position. And so if I did one side versus the other on different days, it could move things internally, which can affect their treatment. But again, thank you, everybody. Hope we answered your questions.
Thank you, Scott.